مساء الخير أو صباح الخير. أنا دكتورة نرمين بدير، مدرس الأمراض الجلدية. برحب بيكم في الموديول. إحنا متهيألي انتوا خدتوا كذا محاضرة قبل كده، دي مش أول محاضرة بس أول محاضرة معايا أنا. أنا هتكلم النهاردة عن سيمتوم بيجيلك في العيادة، أنت محتاج تعرف هتفرق بين الحالات المختلفة للسيمتوم ده إزاي. We will discuss clinical approach to a patient with red face or patient with facial erythema. What's the meaning of red face? What do we refer to? What are we referring to when we say facial erythema or facial redness? Facial erythema or redness denotes cutaneous blood vessels dilatation. When I see skin is red or erythematous, I know that this condition contains the vasodilatation of superficial cutaneous blood vessels. So blood flow to the skin has increased. That's why the skin looks erythematous or red. Clinical erythema or facial redness is a clinical term. It's not a diagnosis. It's not a pathological term. It's not histopathological term. It's clinical. It's a finding that we see clinically. I see the patient, I see the erythema. This is not a diagnosis, it's a symptom. It's more notable when patient is fair-skinned. In dark-skinned patients, erythema is less notable because melanin covers the redness that resulting from vasodilatation. Can red face be physiological? Can we see physiologically facial erythema? Yes, the answer is yes. I bet all of you have noticed some facial erythema in emotional stress, distress, in embarrassment, in anger, all after sun exposure. Every single person has went through some time of physiological facial erythema. Sorry. However, what we are discussing today is pathological facial erythema. When can I say that this facial erythema is not physiological? It's pathological. It does not change with time. It does not change with changing conditions. This is not physiological erythema. So today we have certain conditions. All of them can cause facial erythema. I usually suggest that this slide should be read after our lecture, not before our lecture. You will see it again at the end of this lecture. By the end of this lecture, you should be able to distinguish different types of facial erythema mentioned here. So today I have a patient. My patient is complaining of facial erythema. How am I going to assess this patient? The first step is to determine the differential diagnosis of the conditions that could be the cause of this erythema. That's what we are discussing today. I should also recognize the associated symptom. I should take very good history from the patient about the starting of this condition, exacerbating factors, any other manifestations like itching, anything. Associated manifestations can lead to the diagnosis. So today I have seen this patient. This is the first case that entered our clinic today with complaining of facial erythema. How can we describe this lesion? What is the description of this lesion? I don't need a diagnosis, I just need a description. Please. First, this patient has facial plaques. If you're seeing here, these are plaques. They are slightly raised with texture different from the skin, surrounding skin. So the patient has red plaques covering his face. Red plaques, if I look closely, you will find some scales in this patient. Scales are yellowish, skin is somehow greasy, and the lesion is involving the eyebrow, upper eyebrows, upper lip, all the hairy areas of the face, and it also involves the depth of nasolabial fold. There are very few conditions that affect the depth of nasolabial fold. Today, while discussing other conditions, we will mention many times that nasolabial folds are spared. However, in this condition, the nasolabial fold is affected and to the depth. This is a case of seborrheic dermatitis. Seborrheic dermatitis is a condition results from seborrheic skin or oily skin. Usually, seborrheic dermatitis is more frequently occur in the scalp. You will discuss this in another lecture about scaly scalp, but it also can affect the face, like these conditions. In dark-skinned individuals, you will notice that the lesions look like hypopigmented rather than erythematous, but it looks very erythematous in fair-skinned individuals. Like we said, erythema is more evident, more clear in fair-skinned patients than dark-skinned patients. So, back to this condition. What happens in seborrheic dermatitis? We need to know what the pathogenesis of seborrheic dermatitis in order to determine how to treat. What happens is there are two events. First event, that the sebum, excess sebum of the skin causes dermatitis in this area. Sebum is usually more in hairy areas where terminal hair is present. Sebum is more than vellus hair. That's why in cases of seborrheic dermatitis, we always notice that the hairy areas of the face, like the eyebrows, like the upper lip, are more frequently affected than other areas. Why? Because the terminal hair in the pilosebaceous unit contracts and causes sebum to be more excreted from this area. That's why seborrheic dermatitis is more frequent in the scalp, because it's the source of all terminal hairs, or most terminal hairs of the body. So this patient has excess sebum. Excess sebum caused inflammation or dermatitis. This patient also has a commensal, like every one of us, me, every one of you has a fungal commensal living all over the skin called Malassezia furfur. Malassezia is lipophilic. It loves oil. It loves sebum. It loves the oily environment. That's why when we give Malassezia this oily skin, Malassezia enjoys it and starts to colonizes everywhere. So this patient has two events. The first event, that sebum caused dermatitis or caused inflammation, and Malassezia found this environment convenient for its colonization. How am I going to treat this patient? Is by correcting both events. How is that? I need to correct the dermatitis by anti-inflammatory. I need to correct this fungal colonization by antifungal. So simply, seborrheic dermatitis treatment should contain both anti-inflammatory or topical steroid, as well as antifungal topical creams. Both of them treat seborrheic dermatitis. When I choose steroids in this case, I should very closely take care to use low potency topical steroid. This is an important thing to notice. What topical steroid do I choose to treat this patient? I choose a low potency steroid. Why? And what's the meaning of low potency? Steroids are categorized according to its potency, its effectiveness, into low potency and high potency. So if they are more potent or more effective, why do you use low potency? Actually, the stronger steroid is, the more side effects it causes. That's why we have to balance between the potency and the side effects. When we treat anything in the face, the same goes for when we treat a child. We choose low potency. Why? Because high potency steroids causes side effects. Side effects of topical steroids will be discussed in details in another lecture, but in this lecture I need to mention that one of the very famous side effects of using potent steroid on the face is another condition that we going to discuss today, that is rosacea. We will discuss this in a minute. So, to wrap up, we use low potency topical steroids during seborrheic dermatitis flare with topical antifungal treatment, and in between flare we can decrease the incidence of dermatitis by using anti-dandruff shampoo, which is antifungal shampoo. All anti-dandruff shampoos contain an antifungal active ingredient, that's maybe ketoconazole, selenium sulfide, zinc pyrithione. If the patient is resistant to any of these, we change the active ingredient, not the trade name. If the patient doesn't respond to zinc pyrithione, I change it to ketoconazole, whatever the trade name is. So this patient with seborrheic dermatitis will be treated with mildly potent steroid or low potent steroid with topical antifungal, and will be instructed to use anti-dandruff shampoo or antifungal shampoo in between flares. This is the second patient into our clinic today. This is usually a middle-aged female, 30-something. However, this patient is not only complaining of red face. If she ever mentioned even red face, she usually complains of other symptoms. She usually mentions that she feels pain, tingling, many other symptoms than red face. Actually, facial erythema in this patient is not their first complaint, unlike seborrheic dermatitis. This patient usually has facial erythema that covers facial convexities, the chin, the cheek, the nose, in the form of telangiectasia. What's telangiectasia? I'll be explaining in a minute. This patient has no scales, her skin is not greasy, she just has red skin or facial erythema, and she's usually complaining of pain. Her face is painful. This is a case of rosacea. So what's rosacea? Rosacea is dilated tortuous cutaneous blood vessels. We have just mentioned that cutaneous blood vessels can be dilated physiologically during heat exposure, sun exposure. Anything that causes physiological vasodilatation can cause redness in the face. However, what happens in a patient with rosacea, that their blood vessels are unable to go back to normal after this stressor or this stimulus that causes vasodilatation has been resolved. So this patient is exposed to heat. When she was exposed to heat, she has cutaneous blood vessels. She leaves the hot area going to normal. However, her blood vessels do not go back to normal and still dilated. That's what she specifically say. My face is hot even when I'm in an air-conditioned room. That's actually patient's own terms. So what else? There are several clinical types of rosacea. Yes, we don't call them separate entities. They are actually different forms of the same spectrum. Patient can come to you complaining of only telangiectasia. Telangiectasia means dilated tortuous superficial skin blood vessels. This is an early stage called erythematous rosacea. Erythematotelangiectatic rosacea. Erythematotelangiectatic means it's erythematous and containing telangiectasia. This is a very early stage of rosacea. Yet, patient in time develops some papules on her face looking like acne. Look to the patient on your left side. You may think this patient has acne. She has redness, she has papules, she has some pustules on her face. However, this is not acne. How do I differentiate between a case of rosacea with papules and pustules and a case with acne? I will not find any comedones in this rosacea patient. However, in an acne patient, comedones are the primary lesion, are the first thing we notice. So this patient has both erythema, telangiectasia with papules and pustules. We call this papulopustular rosacea, another stage of the rosacea spectrum, papulopustular rosacea. So this is the second stage. They're all the same spectrum. They all have vasodilatation. They all have erythema and telangiectasia. Another is some condition called phimosis rosacea, phimosis with PH. What happens? This happens when a patient neglects treating rosacea that affects his nasal blood vessels. Nose as an acral part with dilated blood vessels, it causes enlargement of skin on his dilatation of skin and sebaceous glands and everything. So his nose enlarges. It's called rhinophyma. It can happen in other acral parts like the chin, but less commonly, and we call this mentophyma. When the patient reaches this stage of rhinophyma, it's not medical treatment anymore. This patient needs more physical and surgical correction because we cannot just apply some medicine that turns his nose back to normal. So in this patient, he has rhinophyma, which is a very late stage of rosacea. There is another organ other than skin that's affected by rosacea, which is his eyes. Eyes are also affected by rosacea. What happens in eyes? We see dilatation of conjunctival blood vessels. In the same way. Conjunctival blood vessels are dilated and tortuous, and they are unable to go back to normal after the end of the stress. That's heat, probably heat or sun exposure. Patient typically complains of foreign body sensation. I feel like sand in my eye. I don't know what's wrong, but no matter how much I wash my face, I still feel foreign bodies in my eyes. That's patient's own words. This patient needs to be referred to an ophthalmologist. So what are the clinical types, or what are the spectrum of rosacea? First, we have erythematotelangiectatic rosacea, then papulopustular. In the late stage, we have phimosis rosacea, rhinophyma or mentophyma, and we also have eye or ophthalmic rosacea due to dilatation of conjunctival blood vessels. When you discuss the history, you have to ask your patient about the triggering factors. What are the triggering factors? The triggering factors are everything that causes dilatation of the blood vessels. You have to ask her. Why am I using the term her here? Because in most cases, or statistically, your patient will be a female patient. Most patients with rosacea are middle-aged females. So this patient is usually a female, middle-aged, complaining of dilated facial or eye blood vessels. You have to ask her about triggering factors. What happens in rosacea is we have vasodilatation that is not corrected after correction of the stresses. However, we have no idea what happens that prevent these vessels to go back to normal. Yet we have some associated factors that we strongly think are related to this condition, like some parasite infection called Demodex folliculorum. When we examine the skin of rosacea patient, we found this mite in skin orifices, and we strongly think that Demodex folliculorum mite is associated with cases with rosacea. When I ask the patient about the triggering factor, I have to ask her specifically about every condition that causes vasodilatation, cutaneous vasodilatation, like heat, like sun exposure, like drinking very hot beverages, like eating hot food or spicy food, or consuming alcohol. And patient has to be instructed to stop all these triggering factors. For how long? For life. Yes, this patient has a chronic condition that might be a lifelong condition that needs some modification of her lifestyle and to stop or to avoid all the triggering factors. So now we discussed history. We asked the patient to avoid all triggering factors. Now we're going to medical treatment. We usually treat patient with medicine according to her clinical type or clinical stage. Like what? First, this patient is in the stage of erythema-telangiectatic. I offer her treatments that causes vasoconstriction. What physiologically can cause vasoconstriction? What? Beta blockers, yes. And alpha agonists, yes. Exactly. That's what we usually prescribe this patient. This patient is prescribed beta blockers or alpha agonist. One of the most effective and most common treatments for rosacea is bromidine eye drops for eye rosacea, or bromidine gel for skin rosacea, used to cause vasoconstriction of dilated blood vessels. It's an alpha agonist treatment. What if the patient has papules and pustules in a papulopustular stage? We use some topical products for acne, like sulfur cleansers or azelaic acid, or erythromycin topical antibiotic. When we use erythromycin here, we don't use it as an antibiotic but an anti-inflammatory. Why? Why do I use erythromycin as an anti-inflammatory while we do have other anti-inflammatory drugs? Yes, because anti-inflammatory drugs are topical steroids, and in this case, we cannot use topical steroid with rosacea patients because topical steroids causes rosacea. Yes, so I here use erythromycin ointments or creams for anti-inflammatory effect, not for antibacterial effect. However, we use other antimicrobial treatment like metronidazole, yes, the same as Flagyl, but in topical form. Why? To get rid of the Demodex folliculorum that causes rosacea in these conditions. If this topical treatment fails, we usually go for oral treatment or systemic treatment. We use oral antibiotics for the very same reason. We use them for their anti-inflammatory effect, not for their antibacterial effect, because patient develops resistance either way, but he benefits or she benefits from the anti-inflammatory effect of the antibiotics here. We use isotretinoins, but in a very low dose. Unlike acne, we use these in a very low dose, like 10 milligram every other day, means 5 milligram daily, but to commercial forms of isotretinoin don't have a 5 milligram dose. We use 1 capsule of 10 milligram every other day for papules and pustules. So now we have another patient in our clinic that is complaining also of red face. This case is different. This case is complaining of some plaques that are spreading on photo-distributed. What's the meaning of photo-distributed? It means plaques are spreading in areas that are sun exposed. This means it will never affect the depth of nasolabial fold, unlike seborrheic dermatitis and unlike another condition that are we discussing later today. This patient has no lesions whatsoever in the depth of nasolabial fold. Now, a patient has photo-distributed plaques. These plaques are scaly and the scale is adherent. If I try to remove this scale, I will find out it's very adherent. If I manage to remove the scale, I will find dilated pore that contains a keratinous plug or horny plug inside. The lesion is indurated. What's the meaning of indurated lesion? Indurated lesions are deep lesions. They have a deep extension beyond what I'm seeing on the scan. When I hold this lesion, I will find out it's like more deep in the skin. I can hold the whole skin between my fingers like there is a coin underneath the skin. This is the meaning of indurated lesions. This lesion is scarring. The skin is permanently damaged where this lesion is. It usually spares in nasal creases, nasolabial fold, unlike dermatomyositis that are we discussing later today. So the diagnosis of this patient is probably discoid lupus erythematosus. I'm not sure whether you studied lupus erythematosus or not. It should be why you should study it soon. Where does these lesions appear? They appear on photo-distributed areas, cheeks, nasal bridge, on the ears, on the side of the neck, on the scalp, on the dorsa of hands. It's usually erythematous indurated plaques. When you treat this patient can heal, leaving a discoid LE scar. That's a permanent scar, unfortunately. It's depressed with central atrophy. When you examine it closely, you will find telangiectasia on the surface of the scar. The scar is usually hypopigmented, surrounded by hyperpigmentation. So, when a patient has discoid LE, discoid lupus erythematosus, does this mean that he necessarily has systemic lupus erythematosus? The answer is no, not necessarily, but this patient might have systemic lupus erythematosus. Actually, 1 of every 3 patients you see with discoid lupus will turn out to be a case of systemic lupus erythematosus. So these are the screening criteria for systemic lupus. You will study them in detail when you study systemic lupus. I have to screen all patients with discoid lupus for systemic lupus erythematosus. When you look for this, you will find out that discoid rash or discoid lesions are one of the probable signs of systemic lupus. So, can this patient be only a systemic lupus, discoid lupus case with no systemic lupus? The answer is yes. This patient could have discoid lupus alone, but it could be a part of systemic lupus. That's why every case with discoid lupus has to be screened for systemic. So how do I treat this patient? How do I treat a patient with discoid LE that does not have systemic lupus erythematosus after screening? This patient has photo distribution of his lesions, so he needs some protective measures. What do we use here as a sun protection? We, after applying all sun protective measures that we are going to discuss in another lecture, we prescribe this patient with antimalarials. What do antimalarials do in these patients? Antimalarials have two main methods to treat discoid LE. First, it acts like as a systemic sunscreen. Oral antimalarial can protect this patient against sun ultraviolet rays systemically, systemic sunscreen. The second acts as an immunomodulator or immunosuppressant. Of course, discoid LE is an autoimmune disease where body contains autoantibodies, again, immune system forms autoantibodies against own cells. So patient needs systemic antimalarials. When I prescribe systemic antimalarials, I ask the patient to periodically examine his eyes. I refer this patient to an ophthalmologist for slit lamp examination. What else? This patient needs topical or intralesional steroids. This patient also uses topical calcineurin inhibitors. Calcineurin inhibitors are immunosuppressants that are used for patients with transplantation. We use their topical form, their ointment form or cream form in this patient as an immunosuppressant that improves this condition. If the disease is resistant, we start use systemic immunosuppressants like methotrexate, mycophenolate mofetil, and thalidomide. Here, in this case, systemic corticosteroids are controversial. It's not exactly avoided, but controversial. Some doctors prefer using them, while other doctors prefer not using systemic steroids at all. This patient is close to the other patient, yet this patient has erythema, affects the whole cheeks and nasal bridge. We call this malar rash. It's a butterfly-like rash. This is systemic lupus erythematosus rash. Systemic lupus erythematosus is very common with patients with discoid lesions. That's why we usually say these patients has to be examined or screened for systemic lupus. So in systemic lupus erythematosus cases are treated with systemic steroids, not only topical steroids. Now, please describe this lesion. This patient, first thing you say about this patient is that he has fair skin, light skin. When you ask this patient about his history, you will find out that he has a history of sun exposure. You will find the lesion in the form of erythema that affects the whole exposed area of the skin. Patient will also complain of pain, tenderness, maybe itching, sometimes swelling. Some patients even develop blisters. If the lesion involves a large area of the body, this patient might also complain of systemic manifestations like headache, fever, nausea, or fatigue. This is a clear case of sunburn or photosensitivity. The first thing about sunburn, we need to know how we categorize our patients according to their reaction to sun exposure. We have skin types, 6 skin types according to patient's own reaction to sun exposure. What are the skin types? Here are the types 1, 2, 3 to 6 according to their reaction. What's that? What happens? In the first type, or type 1, this patient will burn very easily and severely at the very little exposure to sun. This patient cannot tolerate sun exposure. Usually these are patients that are blonde hair with blue eyes. Skin type 1 is very sensitive to the sun exposure. However, this patient does have melanin. This patient is not albino. He does have melanin, but yet he cannot be exposed to the sun. Skin type 2, he may have minimal tanning, but still burn very easily upon sun exposure. These are blonde or brown hair with hazel eyes. Skin type 3 are in what we see in Egypt as fair-skinned Egyptians. They are usually skin type 3, not skin type 1 or 2. We hardly ever see Egyptian patients with skin type 1 or 2. Average Caucasian skin is usually type 3. They burn moderately and they usually tan upon exposure. Skin type 5 is with dark eyes, dark brown hair. Some Upper Egyptians are skin type 4, yet skin type 5 and 6 is usually very dark skin and hardly ever burn, usually tan. We use this to describe the skin type and to predict their reaction to sun exposure or ultraviolet rays exposure. So sunburn is called phototoxicity. What's the meaning of phototoxicity? And why do we need this in this case? In some cases, we can have a patient with skin type 5 and he has a history of sun exposure of 1 hour or so, yet this patient got burned. How can this happen? This is phototoxicity. What's meaning of phototoxicity? It's usually a drug reaction. We will discuss it in another lecture on drug reactions. I just need you to know the difference between phototoxicity and photoallergy. The phototoxicity is the typical sunburn you see. That is a reaction that happens to exposed skin, only exposed skin upon sun exposure. It happens acutely, and it means that ultraviolet rays caused singlet oxygen release. That's why it caused burn. Yet in photoallergy, there is allergy. The term allergy means that immune system has been triggered. What happens here is that sun exposure causes some sort of immunologically active compound. This immunologically active compound stimulated the immune system. If the immune system generates antibodies, these antibodies will not only affect sun-exposed areas, but it will affect everywhere in the skin. That's why these lesions of photoallergy can cause like sunburn lesions in hidden areas or covered areas. We will discuss this in details in drug reactions. So Sunburn affects only exposed skin. When you notice here, you will find out that anywhere that is covered is not burnt. Only areas that are sun exposed are burned. In some cases, like here, patient can have a very severe burn that causes blistering, like a second-degree burn. Yes, sunburn can be that bad. How do we treat a sunburn case? First thing, you have to instruct this patient to stop exposure, to stop sun exposure. If you are sunburned, you cannot continue to be exposed to the sun. First, stop sun exposure. Even if you are on vacation, you have to start using soothing treatment to the burning skin called compresses, cold bath. Some moisturizers can be very good. Aloe vera gels are very good also. It has to be fragrance free. You cannot apply a moisturizer with a fragrance. Fragrance itself can be very irritating to the burnt skin. Should we use non-steroidal anti-inflammatory drugs or anti-inflammatories? Usually we use systemic anti-inflammatory drugs during the first 24 hours of sun exposure that caused sunburn, because afterwards these non-steroidal anti-inflammatory drugs will do no benefit, and as inflammation has already been established. Topical steroids are always effective, very effective in cases with sunburn. We do not use anything that causes irritation. We do not use topical anesthetics like Pridocaine or something, because all this can be very irritating to burnt skin. This is how to differentiate between phototoxic and photoallergic reaction. We will discuss this in details in another lecture. Now, this is the last patient we have today in our clinic. This patient has a different lesion. You may try to describe this lesion. This patient has erythema. He has erythematous plaques. These erythematous plaques covers his face, involving lower eyelids. Erythema is slightly violaceous. And if we look closely to the conjunctiva here, we will not find any vasodilatation. This is unlike rosacea. No, although this involves the lower eyelid, this patient has no vasodilatation in his conjunctiva. Another thing, this patient has affection in the depth of nasolabial fold. We had another case with this sign, that is, yes, seborrheic dermatitis. This patient also has affection in the depth of nasolabial fold. Unlike discoid LE or systemic lupus, this patient, although has another autoimmune disease, does have involvement of nasolabial fold. Another thing I need you to notice, that this lesion on his arms, although very small, this patient has what we call poikiloderma. What's poikiloderma? Poikiloderma means skin hypo with hyperpigmentation and telangiectasia. This is called poikiloderma. This patient has a condition called dermatomyositis. Patient has violaceous or red heliotrope. I will explain what heliotrope is in a minute. Heliotrope erythema. It involves eyelid, upper cheeks, forehead, temples, and involves also nasolabial folds. This patient also has poikiloderma. Poikiloderma means hyperpigmentation with telangiectasia and some atrophy. This patient has dermatomyositis. Dermatomyositis. This is a two syllables word, and you have to notice dermatomyositis. What's dermatomyositis? This is the heliotrope erythema. Dermatomyositis is a disease of two manifestations. cutaneous manifestations, and muscles manifestations. It's primarily autoantibodies against muscles. However, because muscles and skin have some antigenic similarities, autoantibodies also attack skin. Okay? Okay. What are the skin manifestations in this patient? Skin manifestations are, we discussed some of them. What are they? Heliotrope erythema. Heliotrope is a plant with purple rose. That's why this is heliotrope erythema. Erythema with some violaceous tinge. Cutaneous manifestations contain heliotrope erythema. We described this. We already described this. Contains poikiloderma. We already described this. This patient also has other manifestations called Guttron papules. Guttron papules are papules covering or all his knuckles. We will see a picture of these in a minute. This patient has dilated capillary loops in their nail folds. When we examine the nail folds, especially with a dermoscope, we will find capillaries to be dilated. This patient has calcinosis cutis, calcium deposited on the skin. Typically, calcium deposited in the skin. We will see pictures of all these in a minute. This patient also has Raynaud's phenomenon. Raynaud's phenomenon means vasoconstriction of acral blood vessels upon exposure to cold. You should be aware of this from physiology. What's the muscle involvement in this patient? This patient will be complaining of proximal muscle weakness. You will ask the patient if she or he has certain weakness. Patient will describe typically weakness of proximal muscles. How? He will say he has some difficulty climbing stairs. He has some difficulty standing up from a chair. He has difficulty combing hair. These are moves that involves muscles of the hip, muscles of the shoulder. All these are proximal muscles. So this patient has proximal muscle weakness. Typically, only proximal or mostly proximal muscles are affected. Can this patient has cutaneous manifestations with no muscle involvement at all? Yes, we call this amyopathic dermatomyositis, which means dermatomyositis with no muscle involvement, non-myopathic dermatomyositis. Can this patient have muscle involvement without cutaneous manifestations at all? Yes, and we call this polymyositis. Polymyositis means involvement of the muscles that does not include the skin. These are Guttron papules. If you look closely, you will find these Guttron papules. The knuckles are covered with some shiny reddish papules. These are the calcinosis cutis. Calcinosis cutis is typically calcium deposits of the skin. If we start removing these, we will find chalky material, a material that is chalk-like, present deposited underneath the skin, calcinosis cutis. How do I diagnose the dermatomyositis? I took the history. The patient complains of proximal muscle weakness. The patient has typical erythema, typical Guttron papules, typical everything. How do I diagnose these patients? What is the workup for these patients? First, this patient needs muscle biopsy. So if the muscle biopsy showed a dermatomyositis, can I follow up with other biopsies? The answer is simply, of course, no. We need another investigation to follow up this patient. Muscle biopsy and electromyography. Electromyography is the investigation that can show us the status of muscle weakness. Then we check other labs, blood tests that contains serum phosphokinase and glutamic oxaloacetic transaminase. Both of them you must have heard from other conditions involving bones, involving liver, so they are non-specific. So how do I diagnose dermatomyositis by a non-specific investigations, that's not the condition. Usually we use these to follow up the patient because it's a blood test, so it's easy after diagnosis, after establishment of the diagnosis. It's not specific, but it's very helpful in following up this patient. Now go to this, exclude underlying carcinoma. What does this mean? Why should I look for an underlying carcinoma in these patients? We have a term we use that is paraneoplastic skin conditions. Paraneoplastic means that I have a skin condition that denotes there is an ongoing tumor, ongoing cancer inside. Dermatomyositis is one of these paraneoplastic conditions. So does this patient have a cancer? Not necessarily. But if I have a patient with typical dermatomyositis and the patient is of old age, I have to look for an underlying carcinoma that causes this to be happening. Usually, these patients have an underlying carcinoma. It's called paraneoplastic conditions. Now, this patient has to be treated. How do I treat this patient? First, you have to ask the patient to rest his muscles. It's very essential that muscles get rest. And every patient you instruct to get rest, you have to prescribe physiotherapy for this patient. So after treatment, he wouldn't find that his muscles are atrophic and stiff. Sun avoidance is a must. Now, what are medicines that we prescribe? This patient needs systemic steroids for very high doses, can reach up to 120 milligram per day, and taper very slowly. Afterwards, this patient may also have other immunosuppressant treatments like azathioprine or methotrexate, but the first line of treatment is steroids. So please describe this lesion. This is the last patient. I promise, not the last patient, not the former patient. These are erythematous plaques covering face, itchy, scaly, and the patient is a young child. This is atopic dermatitis. We have a whole lecture on atopic dermatitis that we are discussing soon. This is, in this case, atopic dermatitis in children that are less than 2 years of age can affect the face. We will discuss atopic dermatitis in details. Please describe this lesion. This patient has well-defined plaques, very well-defined border, localized with active border, and if we notice, we will find the center is healing. This patient has tinea facial. Yes, tinea facial is very common in the beard, very well-defined. Describe this lesion. This is another case with facial erythema. These are localized, well-defined, scaly, at the site of exposure to an insult. This patient had some sort of makeup that caused her this lesion. This is a case of allergic contact dermatitis. This too will be discussed in details in another. So thank you very much. This was a lecture on differential diagnosis of a red face. Thank you.